So today I'm gonna be covering the topic which is basically urology. So start from the page 4. So urology history is basically OPQRST approach and urinary habits. We will ask for LUTs, basically lower urinary tract symptoms, which is basically storage symptoms, voiding symptoms, dysuria, hematuria, and incontinence. In storage symptoms, we ask for fun, basically frequency, urgency, nocturia, and D is basically dysuria. So then comes this shed is basically stream changes, straining, hesitancy, incomplete, emptying, and post void dribbling. Then is hematuria, basically blood clots in the urine, and red pink tinged urine, incontinence, stress, urgency, mixed, and overflow. Then is sexual dysfunction, sexual function, which is scrotal mass, erectile dysfunction, and we'll ask for female sexual history like dyspareunia, low desire, and arousal disorders, orgasmic dysfunction, infertility. Associated symptoms basically nausea, vomiting, and bowel dysfunction. Constitutional symptoms is fever, chills, unintentional weight loss, night sweats, fatigue, malaise, bone mass. And then risk factors basically past urological disease like UTI, stones, STIs, cancer, anatomical abnormalities, family history, and then medication and lifestyle symptoms like smoking, alcohol, inactivity, trauma, and previous surgical procedures. On the side, there is always it's written that always ask about the sexual functions in the history. Changes in the erectile function can be one of the first symptoms that there is a concomitant vascular disease, like basically it can be diabetes mellitus and coronary artery disease. So if somebody comes with the sexual dysfunction, what is in our history, we have to always rule out about diabetes and about hypertension. So these are the main first two factors that we have to rule out before going further. So then comes is hematuria, so amount of blood that is present in the urine and which can be seen with the naked eye. So basically gross painless hematuria in adults is basically bladder cancer. So if until proven otherwise, so if a patient comes to you like a 60-year-old male comes to you with a hematuria and he doesn't have any pain and it's been the hematuria symptoms has been coming for like 5 to 10 days, so we are going to investigate for the bladder cancer, especially in old male. But more than 45 we can consider as a bladder cancer, so we have to rule out all the signs and symptoms of the bladder cancer and do investigation of the bladder cancer. So it is bladder cancer until proven otherwise. Then comes the etiology by the age group. Then 0 to 20 is basically UTI. So in the like young males up to like 40, we can think of UTI and glomerulonephritis, like congenital anomalies, stones, bladder tumors, and exercise. The first thing that is very important is basically UTI. Up till age of the 40, from the very start, it is basically the most important is UTI. Then from the 40 onwards up till like more than 60, then it comes the tumor. And in male, it's basically bladder tumor. In female, it's basically UTI. Still, we are thinking of UTI. In male, the bladder tumor is very important, and in female, if somebody is taking chemotherapy, then definitely, and smoking, then definitely we go for the bladder tumor. And then stones, UTI, bladder cancer, and then in the male more than 60s, BPH, bladder tumor, UTI, RCC, prostate cancer, female, and bladder tumor, UTI, and RCC. So the important question here is basically painless hematuria with the in adults is basically bladder cancer. So the next part is table 2. Etiology by the type is basically pseudohematuria like vaginal bleeding, dyes, beads, rhodamine B in the candy and the juices. Hemoglobin is basically hemolytic anemia. Myoglobin is rhabdomyolysis like drugs, rifampin, phenoxypyridine, phenytoin, porphyria, laxatives, and then infection is pyelonephritis, cystitis, urethritis, glomerulonephritis, interstitial nephritis, tuberculosis. Then is malignancy is basically renal cell carcinoma, urothelial cancer, Wilms tumor, prostate cancer, and leukemia. Then comes the benign is basically BPH, polyps, and exercise induced and structural stones, trauma, and foreign body, stricture, polycystic, as we already know, those all structural things that is causing the problem, like fistula and hydronephrosis and AV malformation. Then is hematological, basically all anticoagulant and then coagulation defects, sickle cell disease, and thromboembolism. Then on the sidebar, there's written common urological causes of the hematuria. So all of these were the causes of hematuria, but what are the most common? It could be trauma, it could be tumor, it could be toxins, it could be infection, inflammatory calculi, cysts, and surgery, and sickle cell, and other hematological causes. So then comes is basically like history, as we have already know, then and we need to know that the timing of hematuria, if it's initial then it's basically in anterior urethra, if it's terminal then it's basically bladder and neck and prostate urethra, then total is basically bladder and above. So basically urethra, neck and everything could be the cause. And then it's basically like bladder and above, I means like kidney, ureters, those ones. So presence of the blood clots, it means this is a trauma or something. And LTUTS, like lower urinary tract symptoms and associated symptoms like pyuria, dysuria is basically UTI is very common in that. So flank pain, radiations, and urethral obstruction. So last menopause is basically very important in the female, and history of kidney stones, UTI, or the previous urological surgery. Recent UTI, post-infectious glomerulonephritis, IgA nephropathy. Medications could be anticoagulant, rifampin, phenoxypyridine, and phenytoin. Risk factors of malignancies like smoking, chemical exposure, history of cyclophosphamide. That is very important. In all the chemotherapy, the most important drug that causes the malignancy of the bladder is basically cyclophosphamide. So then comes is basically pelvic radiations. Then we ask for the investigation like urine analysis, urine culture and sensitivity, urine cytology imaging is basically lower tract cystoscopy, upper tract is basically CT urogram. So we are going to do CT, right? And that is basically gold standard. But still we start from CBC and urine analysis and urine culture and sensitivity. So that comes as the definitive treatment. Ultrasound. Then is basically electrolytes, creatinine, BUN if you are thinking of kidney failure, and low GFR. So all of those things. INR, PTT, and PSA in the men. Acute management of severe bladder hemorrhage is basically manual irrigation via catheter with a normal saline to remove clots. So basically, if it comes as a trauma, what are we going to do is we're going to remove all the clots by what we're going to do is basically manual irrigation of the catheter. And then comes this continuous bladder irrigation using like a large three-way Foley. So we are going to pass the fluid from one and taking out from the other one. So that's why we're going to use three-way Foleys. To prevent clot formation should be done with basically off-bout manual irrigation. So what could be the answer in the bladder trauma? So if there is a blood clots present, what we're going to do is basically irrigation via catheter. And what we're going to do is basically continuous bladder irrigation. So we have to remove all the clots and the bloods until it's basically all the clot free. Then it's basically cystoscopy. We have to see what's inside, like tumor, trauma, source, coagulation, obvious sites of the bleeding, and transurethral section of the tumors under general or the regional anesthesia. Then on the side is basically upper tract imaging options. What are those options? Are basically CT urography, ultrasound, and magnetic resonance, MR. So what is CT urography? Is like a test of choice to evaluate for renal parenchyma. So we have to, if we want to see the renal, then we have to do is CT urography, as we have already did. That is the gold standard, right? Then comes the ultrasound. That is basically we have to see renal parenchymas, renal cells, like limited sensitivity to the urothelial carcinoma. So in the ultrasound we cannot see what is like, it's basically what's inside, like is it a carcinoma or what is going on. So what happens is then comes is like magnetic resonance urography, that is like more obvious than the ultrasound, and evaluation of the renal parenchyma system and congenital anomalies beneficial in the pediatrics. Very important if you want to go for the pediatric, like a small child who came. So we are not going to jump directly into the X-ray or CT. We can go to the magnetic resonance, and even in pregnant patients when ionizing radiation has to be avoided. So we, in both cases, we do avoid the radiation, and we want to see what is going inside. So what we do is basically magnetic resonance urogram. So if a scenario came with the pregnant woman or the pediatric, then we choose MR urography for the upper tract. That's very important. This is not for the lower tract, this is for the upper tract, because lower tract we can see by doing like urine analysis or stuff like that. Then comes is basically microscopic hematuria, like more than 2 RBCs. Like what we were seeing is basically with the naked eye, there was hematuria. Now comes is microscopic. Microscopic is something which is not visible through eyes, but we can see on microscope. So more than 2 RBCs, if keep on showing up, that means that's basically hematuria, like microscopic. Blood in the urine that is not visible in the naked eye, and more than 2 RBCs on the urine analysis of at least 2 separate samples, like more than 2 RBCs, like that is present. What are we going to do is basically there is a workup that is present, so we have to remember it that way. What happens is more than 2 RBC is present. What we do is identify benign reversible causes, like basically it could be infection, urethral trauma, heavy exercise, menses, or medication. So retest after underlying cause resolved. So what we're going to do is we're going to retest it after underlying, like we have to see if what is going on inside, since it could be infection, it could be trauma, it could be heavy exercise, or anything, rhabdomyolysis is going on, any medication that is causing it. That's why we have to see. So we identify the reversible causes, yes, then we have to retest about after underlying cause resolved. So we have to resolve all the infection and everything, then we check it again that it's resolved or not. Then let's suppose if it's not resolved, then what we're going to do, we are going to check for the glomerular disease. It is basically present inside the kidney, right? So that's why we're going to check for creatinine, proteinuria, RBCs, and RBC cost. So what happened is basically if proteinuria is present, then basically it's nephrotic syndrome. If our creatinine is present, basically kidney is going towards the failure side. And if there's a dysmorphic RBCs, then it means that some like RBCs, like sickle cell anemia or something like that is going on. And then RBC is basically ATN, like acute tubular necrosis kind of thing is going on. So that's why what we're going to do is going to refer to nephrology. If that is not even present, then what are we going to do? We're going to check for the renal ultrasound. Like it might be something bigger that is going on and we cannot see it from those things. So we're going to do renal ultrasound, like maybe my tumor or something like that. Then we are going to also check for the renal urine cytology. We have to see all the cells in the urine. So negative results and low risk factors, we are going to skip to urine analysis, urine cytology. As you can see, if some patient came to the ER with microscopic hematuria, like not ER, but it can come in the clinical setting as well. So if it comes with the microscopic hematuria and you check out there is like more than 2 RBCs present, so we are not directly going to jump into urine analysis and urine cytology. We have to check if it's an infection, if it's what kind of symptoms are going on, and then we can jump directly one by one to the different. And then if it's a low risk, then we go for the urine analysis, urine cytology, BP at like 6, 12. It might be high blood pressure that is causing it. 6, 12, 24, and 36 months. Then it's basically renal ultrasound and urine cytology, but it came out positive. That is definitely something going on. So we have to refer it to urology for cystoscopy to see inside what if there is anything. And if the patient is high risk, like age more than 40, smoking history and occupation exposure, gross hematuria, history of storage or voiding symptoms like history of recurrent UTI or urological disorders and pelvic radiation exposure, in those cases even ultrasound or cystology doesn't come out positive, we are still going to refer to the urologist, because this person is smoking it, this person age is more than 40, which is also itself is a risk factor for the bladder cancer. Okay, then comes is basically lower urinary tract symptoms, which is basically storage phase, voiding phase, lower urinary tract dysfunction, and can be therefore classified as failure to store and void. And 3 symptoms basically storage, voiding, and post voiding. Then on the side is basically transient causes of reversible urinary incontinence and elderly is basically diapers, like delirium, infection, inflammation, atrophic vaginitis, urethritis, pharmaceutical, psychological, excess urine outflow, and mobility retention and stool impaction. Then it comes as basically urine urgency is the complaint of sudden compelling desire to void that is difficult to differ. It is not necessary associated with the incontinence. Then this is stable. This table is very important for the stress is basically if somebody sneeze, cough, and exertion, then because of that intra-abdominal pressure, the urine leaks out. Then urgency is basically leakage preceded by the strong urge to void. Overflow is basically like it's the leakage without any urge to void, so it's like overflowing. Mixed is basically stress plus urgency. So etiology, like we need to know urgency. What happens is basically detrusor overactivity. And the stress is basically sphincter. So how I remember is basically S for stress and S for sphincter incompetence. And then urethral hypermobility, right? So in the stress, the problem is here in the urethral hypermobility. In the urgency, the problem is in detrusor overactivity, and the mixed, it comes as both. And in overflow is like BPH, diabetes mellitus, all those things. So investigation, we go for history. We have to check what kind of incontinence is this, when a leakage occurs, number of pads, lower urinary tract symptoms, neurological disease, pelvic surgery, radiotherapy, and obstetrical history, bowel and the sexual dysfunction, medication impact, anything. And then physical examination is like edema, a general like edema, neurological abnormalities, mobility, cognitive dexterity, and abdomen and distended bladder, genitourinary prolapse in the woman, and DRE in the man. Cough tests like urine analysis, urine culture and sensitivity, voiding diary, type of incontinence, how often, and volume of leakage and urodynamics. So comes the management. What is basically management for the stress incontinence? Weight loss, smoking cessation, Kegel exercises, pelvic floor, muscle therapy, and then comes the surgery, urethral sling or the artificial sphincter in men. Then comes is basically urge incontinence. So in urgency, we have to like look for the fluid management, bladder training, and Kegel exercises. Medication is basically anticholinergic like oxybutynin, beta 3 agonist is basically mirabegron, and botulinum toxin A, bladder injection, and then neuromodulation. For the mixed one, we do have to see what kind of symptoms are coming, and we have to treat according to the symptoms. Then is basically overflow, and then we can do is intermittent catheterization, treat underlying cause. So then comes is basically lower urinary tract and symptoms, urinary retention, the same like fun and shed, we see as already we have read in the top. So if a trauma patient is unable to void, has blood at the urethral meatus, a scrotal hematoma, or high riding prostate, that is a urethral injury until proven otherwise. So if a patient is coming and he's not able to void, and he has basically urethral meatus, scrotal hematoma, and overriding high riding prostate, so that is basically urethral injury, and we are not going to catheterize this patient. Acute and urinary retention is basically, acute retention is a medical emergency characterized by the suprapubic pain and inability to void. Then chronic retention is basically a painless, because it has been happening for so long, so he has developed tolerance to that. So it's a painless with a decrease, greatly increased bladder volume and detrusor overactivity, followed by atony. Patient with ascites may have falsely elevated PVR. That's why it has like a false positive as well, measured by the bladder scan. Post-voidal residual volume basically. Then comes this urinary retention, as we have already read. What happens, the clinical features like suprapubic pain and palpable, and then percussible bladder, purulent and meatal discharge, increased size of the prostate, and anal sphincter tone. On the DRE, we will do check DRE. Then what happens is basically anal sphincter tone is basically increased. Okay, so we have to remember what happens on the DRE is basically anal sphincter tone is reduced or prostate is high. That's why it is happening. Then is neurological, maybe abnormal or deep tendon reflex is reduced, or anal wing saddle anesthesia. Then we are going to check according to the etiology. What is the etiology? It might be like outflow obstruction. Maybe the problem is at the bladder neck or urethra, calculus like stone, any foreign body, neoplasm, neurological, prostate, BPH, prostate cancer, urethra, stricture, phimosis, and traumatic disruption, miscalculaneous, constipation, pelvic pain, and then severe prolapse in the woman. Then comes the bladder intervention. Intracranial is basically maybe cerebrovascular artery problem like tumor, Parkinson's, cerebral palsy, spinal cord injury, disc herniation, multiple sclerosis, diabetes mellitus, and maybe pelvic injury. Pharmacological, basically anticholinergic, narcotics, antihypertensive, OTC, cold medication containing ephedrine and pseudoephedrine, antihistamines and psychomatic substances. MDMA, ecstasy might cause urinary retention as well. Then is infection like UTI, prostatitis, abscess, genital herpes, and induced infected foreign body, and the varicella zoster. Then what are we going to do in the investigations? The investigations basically CBC, electrolytes, creatinine 1, urine analysis, culture and sensitivity, and ultrasound, cystoscopy according to the need. If the patient comes as like a very minor symptoms, then all we're going to do is rule out UTI. It could be like UTI. We can do CBC, like maybe we don't even need to do CBC. We need to do urine analysis, and we can check it, and then we can go with that. So it depends on the patient's symptom, how severe it is. Then we go along with that, like ultrasound, cystoscopy, urodynamic studies, PVR. And then is treatment, like we have to treat the underlying cause. It could be any, as we have already read about what are the etiologies. Then what are we going to do is basically catheterization. If it's an acute, then it's basically painful. Then we have to do is intermittent catheterization to relieve the retention. Leave follies in the drain bladder, follow up to determine cause, and closely monitor fluid status and the electrolytes. Chronic retention is basically intermittent catheterization by patient may be used. Definitive treatment depends on the etiology and all those things. Suprapubic catheter if obstruction, like let's suppose if urethral obstruction and all those trauma happened and high riding prostate, and there is a scrotal hematoma, or there is a blood in the urethral meatus, so we are not going to pass the Foley's catheter. What we're going to do is suprapubic catheter if obstruction precludes urethral catheter. For the post-operative patients with the retention, encourage ambulation like alpha blockers. We can do like tamsulosin in the men. So if a patient is having like BPH or something like that, so we have to relax the bladder neck, and may need catheterization for a longer period of time, and definitive treatment with the depend on the etiology, and minimize narcotic use. So we have to lessen the amount of the opioid. As we have already discussed in the MCQ session, like opioid use is very common, and some might develop the addiction to it. So that's about it. Then I'll go move on to BPH. So if you guys have any question or any suggestions, please let me know in the comment box and we can go along with that. So in each session I'll try to cover as much as I can, and definitely once I'll be able to start my live sessions, then I'll read more read more as much as I can. So till then, see you next time.